I'm very, very thankful to all my colleagues, especially Jose Marcondes, Pirwani, Monica, Professor Anis Bhatti, and others who have responded to our request to participate in this seminar. Uh, I'm going to talk about the guidelines that were developed by this group. Uh, what was the need? What was the background? How these guidelines were developed, and how do we intend to implement. Low and middle income countries carry a large burden of children with club feet. Ponsati clubfoot treatment has high reported long-term efficacy in preserving painless foot function. The available evidence shows the treatment to be more effective than any other non-surgical or surgical intervention. Ponsati International advocates the concept of the Ponsati Club Care Clinic pathway, i.e., from the screening for the foot deformity to discharge, with access, equity, quality, local ownership, and sustainability. However, the reported outcomes of the Ponsati clubfoot treatment were inconsistent. One of the main concerns on the implementation of the Ponsati method was wide variation in its use and changes in the protocol. To ensure professional consensus on the proper implementation of the Ponsati method, Ponsati International decided to formulate the clinical practice guidelines. These guidelines were to ensure that every individual affected by the deformity will receive high quality care based on the current evidence, integrated with clinical expertise and parent or caregiver advice. The guidelines emphasize that each patient should be individually assessed and decisions should be made as to the appropriate management in order to achieve the best clinical outcomes. These guidelines are intended for use by the orthopedic surgeons, pediatricians, medical officers, physiotherapists, orthotists, cast technicians, and other healthcare professionals who are directly involved in the care and management of individuals with clubfoot deformity. They have been developed by the Ponsati International in response to the identified variability and uncertainty in the application of the Ponsati treatment method. These guidelines were developed to serve as a tool to improve the patient care, but obviously they do not replace the central role of the clinical expertise and reasoning in determining the appropriate patient care. It is suggested that the variation from these guidelines should be documented in the patient's medical record at the time the relevant decisions are made. The information in these guidelines is based on the evidence available at the time of writing, and I'm going to elaborate upon it further on expert opinion, and these should be used with an awareness of the more recent evidence. When we talk about guidelines, there are various methodologies as to how to develop guidelines. There are WHO guidelines, there are the American Academy of Orthopedic Surgeons Association guidelines, procedures to develop guidelines. These are quite rigorous, they are unbiased, they are based on thorough review of the literature. They provide grades of recommendation for an investigation or a procedure, but rarely guide the management of a patient throughout the treatment course. They are cumbersome, expensive, and they are not patient specific. The idea of developing guidelines and the method that was chosen by Ponsati International was to focus on what are the needs of the clinician, a common language. They are simple, they are patient specific, they are user-friendly guidelines, and they help in the decision making during the diagnosis, treatment, and follow-up. We looked at the WHO guidelines process, the BMJ guidelines for clinical guidelines, and the NHMRSE from Australia. The BMJ key components of a useful clinical guideline was the identification of key decisions and consequences during the diagnosis, while estimating the prognosis, assessing relevant clinical outcomes, and weighing up various consequences of different options leading to the algorithm or the flowcharts, which we are going to talk about in the next few talks. The idea was to bring relevant, valid evidence that the clinicians need to make informed decisions at each of the key decision points. Evidence must be relevant to the individual patients, and these led to the development of the decision tables. And finally, presentation of evidence and recommendation in a concise, accessible format, these leading to the publication. In order to develop these guidelines, a working group was established in 2012 consisting of pediatric orthopedic surgeons from 6 countries, each with extensive experience in treating patients with clubfoot. The group was supported by the staff of Ponsati International, including experienced global health public professionals, along with partial financial support from the USAID. The approach that was selected was evidence-based, published literature was reviewed, websites were searched, and where there was paucity of high-grade scientific evidence, expert opinion was used to identify the clinical best practices as currently understood. The guideline group consisted of key country and PIA stakeholders, Ponsati Method specialists, professional bodies, public health personnel, and personnel who were informed about the health systems. There were surgeons from 6 countries. It took a 2-year time period. There were 10 web conferences. There were 2 in-person meetings, and each of them declared a no conflict of interest declaration. So this was the guideline drafting team. When we met in Barcelona in the final meeting, finalize all of these, there was the representation from Pakistan, and then you can see the young Hoda Markwende, Shafiq Pirwani, Tom Cook, and Mansoor Ali Khan. See, there's discussions going on between myself and Hoda Markwende. The Pakistan contingent also consisted of Dr. Lubna, who presented a Pehla Qadam mod at that meeting. Anish Bhatti giving his talk. Myself there. This was the General Assembly that finally voted on these guidelines. In the evening tea and snacks in Barcelona, very lovely weather during the time that we were there in June 2014. So the version 1 was developed and released in January 2015. As I said earlier, you can see the team that developed here this manuscript. The idea was that this document will be updated regularly to reflect the changes in the available evidence and practices. What each algorithm contains, and this is very important to see and understand, it contains ovals, which are the entry and exit point. Diamonds are the decision points, and the answer to the diamond is either a yes or a no. And the rectangles identify a procedure that may or may not be done on a patient. So the guidelines were divided into 2 main sections: the diagnosis and classification, and the treatment algorithm. Few words about the diagnostic algorithm. This is the diagnostic algorithm where child comes with a deformity, and this is the oval here where you can see this is the entry point. The decision is here with the diamond, whether it's a history, whether it's a significant history, or a cave, which is cavus, adductus, varus, and equinus. If these are not present, then it is not a clubfoot. Similarly, once a decision is made that this is a clubfoot, then at the next diamond comes in asking whether there are other congenital abnormalities present. If they are present, then this is not an idiopathic clubfoot, but a syndromic clubfoot. If there are no other congenital abnormalities present and it is deemed to be a clubfoot, the next question comes in the diagnostic algorithm is whether the patient has had a previous treatment. If the patient has had a previous treatment and that previous treatment was surgery, then this patient has got what we call a post-surgical foot. If the patient has not had any treatment, then the next question is whether the patient is of a walking age or is not of is not walking yet. So if the patient has got clubfoot and is walking, then we label it as an untreated walking clubfoot. On the other hand, if the patient is not walking and does not have a transverse plantar crease, then this is classified as a untreated, not walking clubfoot. If the patient has a clubfoot, has not had any treatment, is not walking, and has a transverse plantar crease, then this foot would be classified as an atypical clubfoot. If the patient with a clubfoot has had a previous surgery, then this foot would be classified as a post-surgical clubfoot. If the patient has had previous treatment which was not surgery and still has a transverse plantar crease, then this is a complex clubfoot. If the patient has had previous treatment which was surgery and there is no cavus, then this foot is, then no cave, which is cavus, adductus, varus, and equinus, then that foot is labeled as a corrected clubfoot. Whereas if the patient has any element of cave, then this would be labeled as a foot with a persistent deformity. Similarly, on the treatment algorithm side, on the treatment side, the algorithm classifies these foot into untreated not walking, untreated walking, a syndromic, relapsed, or a post-surgical clubfoot. There are talks following this talk looking at each of these algorithms, and I hope that the audience is able to understand what we are trying to present here. Thank you very much.
So welcome back. So we move on to the next talk again by Professor Amin Chinoy, and we'll play the talk in a moment. Yes, please.
Bismillahirrahmanirrahim. Hello, once again here. Going to talk about the late presentation in children. We've gone through the need for the guidelines and the algorithms for the diagnosis, and now we're going to talk about the guidelines and the algorithms about the various types of clubfoot. So what I'm going to talk about is the late presenting clubfoot in children. So these are children who have not presented at birth or in the first few weeks to the hospital and not walking. So these are classified as untreated clubfoot, not walking. So if there is a history of a clubfoot or the child has got a cavus, what we call cave, which is a cavus, adduction, varus, and equinus of the forefoot, and the child does not have any other congenital abnormality or has not had any previous treatment and is not of a walking age and does not have a plantar crease, then this child is classified as having an untreated clubfoot, not walking. So the treatment guidelines start with the counseling of the patient, and this is where the dedicated clubfoot clinics like the Palakadam that we have at Indus are very, very important component where the parents are counseled about it, then the child is registered, and then after the registration, they get it. The Pirwani scoring is done, and the photographs of the feet are taken for record keeping and for entry into the International Clubfoot Registry. It is very important to have dedicated clinics, clubfoot clinics like the Palakadam that we have at the Indus Hospital, because it not only helps to alleviate the anxiety of the parents, because then they understand that it is not only their child who has got this condition, but that this condition is quite prevalent. They can talk to the other parents where they understand the disease better, and they understand the importance of coming to the clinic on a weekly basis for the first few weeks. They understand what is going to happen, that it is they understand the plaster care when they talk to each other. They understand the need of the tenotomy, and that the tenotomy can safely be done without much pain and anxiety to the child under local anesthesia in the clinic. And they also understand that the importance of the long-term bracing that these children, the children with clubfoot, will need to have. So dedicated clubfoot clinics are very, very important for all of these reasons. So once the Pirwani scoring has been done and they entered into the registry, then the child is manipulated and gets a cast. This cast starts from the toes to the high groin. So the first part is the below knee, and the second part is completion to the high groin. So this is one child here who presented at around 3.5 months of age. So this was still an untreated clubfoot, not walking. This is after the first plaster where the foot is supinated to get it in line with the foot, to get the front forefoot in line with the hind foot, and this is after the first cast. Then the same child getting subsequent casts here, and this is after the second plaster, after the third cast. Tenotomy after the fifth cast here in this child. The tenotomy is performed when this child has got more than 70 degree of abduction and 0 degree of dorsiflexion. It is important to understand that tenotomy should not be performed until a dorsiflexion of 0 degree has been achieved. Otherwise, one can actually end up having a rocker bottom foot. So once the tenotomy has been performed, the cast is applied, this cast is removed in 2 to 3 weeks. If on removal of the cast after the tenotomy, the child has got 20 degree of dorsiflexion, then at this stage we apply the brace to the child. Here it is being applied. The parents are being taught as well about how to apply the brace. This is the Iowa brace that is being applied to the child. They are taught about the importance of making sure that the heel is sitting firmly in the base of the footwear, that it is not too tight, that there are no pressure points. And once these have been applied, then they are connected by the connector rod. So this is the connector rod, and in cases where the child is awarded by bilateral deformity, both of them are externally rotated to and abducted to about 70 degrees. If after the 6 casts, the child does not have a 70 degree of abduction or a 0 degree of dorsiflexion, then the 8th cast can be applied. But it is important to make sure this cast corrects all the deformities. If not, then it is imperative to seek additional consultation. When the child's brace has been applied, the parents are educated on the maintenance of the brace. The brace is worn full time for the first 3 months for about 23 hours, and they allowed to be taken off only for bathing and changing purposes. After 3 months, the child is allowed to use the brace only at night. So they have a 12-hour on and a 12-hour off session. So this is at 6 months of bracing, same child. And this child brace has got to be continued till the age of 4 years, at which the brace could be discontinued. The child should be then monitored to maturity on a yearly basis. If the correction is maintained, that is fine. If not, then we will have to, this will be classified as a persistent deformity or a relapse. So here is this child, 1 year of bracing, 2 years of bracing, 3 years of bracing, and at the final visit when the treatment was completed at 4 years. Talking about the clubfoot guidelines for the untreated walking. So this is more than 9 months of age. These are children who are now walking on it, and the guidelines are slightly different because non-weight bearing and weight bearing club feet are subjected to different forces, some of which may have contributed significantly worsening deformity. There may be bony deformities which have become fixed, also the ligamentous and soft tissue are either stretched on one side and contracted on the other side. Untreated walking clubfoot has often been referred to as the neglected clubfoot. This term implies a judgment and indicating that someone, especially the parent or the grandparents, may have been responsible for neglecting this deformity. This may really not be the case because it may be simply a lack of knowledge because of customary customs where clubfoot deformity and the deformities are attributed to solar and lunar eclipse, or these patients may not have had access to available treatment, and that's why they have not been able to get treatment for the child, and that's why it should not be called a neglected clubfoot. And finally, the use of this term really does not provide any information about the treatment or prognosis of this child. So again, a child who's got a history or has got a cave, does not have any congenital abnormality, has not had any previous treatment, but is of a walking age and has been walking on this. And as you can see here in this was a child who was 3.5 years of age at enrollment. One can see the deformity, but as well as one can see the large bunions here on both sides. So once again, the parent counseling is very important. They have to be explained and understand as to what it will entail. And once that has been done, serial manipulation and casting is to be done. The important thing here is to see that the child can get as much of abduction as possible. 70 is the ideal, but we have seen that at around 6 years of age, not more than 50 degrees of abduction is possible. Similarly, a child who is between 6 and 10 years, hardly 40 degrees of abduction is possible. In a child who is over 10 years of age, only about 30 degrees of abduction is possible. But having said that, one should endeavor to get as much of abduction as possible, understanding the limits of the age that the age will impose upon it. Here the other difference is that instead of 0 degree of dorsiflexion, one should try and get about 10 degree of dorsiflexion. If that is not have been achieved by the 6 casts, then the patient may get additional 2 or 3 casts. try and get this abduction. If by the 9 cast there is not adequate abduction or 10 degrees of dorsiflexion, then it has to be understood that this may be due to either a very severe pathology or there may be inappropriate manipulation of casting or casting. And that's why this is not happening. And the thumb may not be actually at the head of the talus and may be at the calcaneocuboid joint. And this, unfortunately, would not allow the to be corrected. So if after 9 casts have been applied and one has not had adequate correction, and then i.e. More than 50 degrees, between 50 and 70 degrees of abduction and more than 10 degrees of dorsiflexion, then it would be time to seek additional consultation. If, however, this child has now obtained 30, 40, or 50 degrees of abduction and 10 degrees of dorsiflexion, then a tenotomy should be performed and a high cast should be applied. And the cast here should be maintained for between 4 to 6 weeks. So here is this child, same child. He's now here after about 4 plasters, after 6 casts. And at this stage, if after the tenotomy has been performed and 10 degrees of dorsiflexion has been achieved, then this child should get a brace. Parent education and counseling should continue and the child should be followed every 3 to 6 years. If, however, after the tenotomy there is still 10 degrees of dorsiflexion, then post-tenotomy manipulation and casting should be done. About 2 more attempts should be given. If at that stage, again, we have more than 10 degrees of dorsiflexion as well as adequate abduction, then the brace should be applied. Otherwise, the child should be referred for additional consultation. Here is the same child who has had this tenotomy and correction, and this after 1 month in brace. This is 1 year in brace, 2 years of the bracing, and 3 years and completed. And this is the final visit of this child at 3 years. One should understand that the brace in these children should be carried on till the child crosses the age limit of 4 years or is 1 year post treatment. If their foot is not corrected, then brace should be applied and continued. If the foot is fully corrected at either of 4 years of age or 1 year post manipulation, post treatment, then the brace should be continued and this child should be monitored to maturity. In cases where on subsequent visits the correction has been maintained, then nothing further needs to be done and the child should be monitored to maturity. If, however, the correction is not maintained, and then this is either a persistent deformity or the child has gone into recurrence or relapse. Few important things to remember here in between these 2 groups of untreated not walking and untreated walking is that goal of 10 degree of dorsiflexion before performing the tenotomy is very much necessary in the child who is of a walking age. Sometimes in older children with more fixed deformities, more casts might be needed. Sometimes once the tenotomy has been performed in a walking child for walking age, at least 6 weeks cast, post-tenotomy cast should be maintained. And reduced criteria of success following the tenotomy has to be accepted, which is only about 10 degrees of dorsiflexion. Follow-up period of 1 year after correction if the patient is over 4 years of age. I thank you very much all. Thank you all very much for a patient listening. Thank you very much.
Thank you, Professor Amin Chinoy. And we quickly move on to the next talk by Professor Mehtab Pirwani.
Allah, most beneficial, most merciful. I'm Professor Mehtab Pirwani. I have been assigned this talk of the clinical guidelines for the management of relapsed and recurrent clubfoot. What is the purpose and the background of this clinical guidelines? To ensure that every individual affected by clubfoot deformity will receive high quality care based on current scientific evidence, integrated with clinical expertise and parent or caregiver advice. It is emphasized that each patient should be individually assessed and decisions made as to appropriate management in order to achieve the best clinical outcome. And how we are going to diagnose that and classify the clubfoot? Clubfoot is a deformity affected by having a cavus, adductus, varus, and equinus of the heel, cave. Different types of clubfoot require different treatment options and have different prognosis. This is the algorithm, deformity, and then we will diagnose that whether it's a syndromic foot, complex foot, or sort of a thing. This is untreated, non-walking, without deep plantar crease, typical clubfoot, and this is untreated with deep crease, atypical clubfoot. This is with genovalgus, syndromic clubfoot, post-surgical with deformity, with the deep crease, with after the treatment. It is a complex clubfoot, and it is a recurrent clubfoot. He had a treatment, and then it relapsed. So my today's topic is relapsed and recurrent clubfoot. This is the algorithm that how we diagnose and treatment accordingly. Following factors should be considered when treating patients with persistent or relapsed clubfoot deformity: difficulty in getting and using braces, the stability and function of the family, logistics related to transportation and religion. The family members, caregivers need to understand the importance of the bracing protocol. The brace should be inspected for evidence of use and appropriate fit, and parents should be able to demonstrate proper application of the brace. At the visit, we will examine the shoes, whether they are putting it properly or they are not putting it properly, and what is the position of the shoes. A foot is fully corrected when all the components of the deformity are normalized and there are 40 to 60 degrees of abduction and 15 degrees of dorsiflexion. The goal of obtaining 15 degrees of ankle dorsiflexion may be accomplished entirely by casting in this group of patients. If this is not possible, perform an Achilles tenotomy as needed. Before performing the tenotomy, the foot should be adequately abducted so that the talar head is fully covered laterally and varus is corrected. Failure to achieve correction of the deformity following repeated casting and tenotomy may indicate inappropriate manipulation and casting, and incomplete tenotomy and additional consultation should be sought at specialized centers. Bracing can be discontinued after the age of 4 years because relapses are uncommon, 5 to 10% of cases after this age. However, if a child has a relatively tight tendocles, then 10 degrees of dorsiflexion only, continuation of the brace for another year may be helpful, as well as performing stretching exercises for the tendocles. The decision to perform tibial anterior transfer TET depends on the age of the patient, recommended older age 30 to 36 months of age, and the adherence to bracing protocols by the parents. In subsequent follow-up, with which the foot should demonstrate maintenance of the correction with no cavus or varus and about 15 degrees of dorsiflexion. If any of the component of the deformity are present, a new lapse will be present and further treatment is advised. Thank you very much for your kind attention.
Okay, welcome back. And thank you, Professor Mehtab Pirwani, for your talk. And we'll move on to our next talk from Dr. Asif Peracha.
Bismillahirrahmanirrahim. I am Dr. Asif Peracha and I am orthopedic surgeon in Liaquat National Hospital.
Screen share.
Topic to given me for discussion is the post-surgical recurrent clubfoot treatment. So, first of all, we should see what are the problems associated with this clubfoot treatment, operated foots. There is because these clubfoot tissues are already pathological, and there are a lot of scarring after surgery that lead to the recurrence of the foot, and very difficult to treat these patients. The second thing is that there is a dynamic supination deformity of the foot. It means actually few authorities says there is some weakness in the peroneal muscle in this type of clubfoot. So this is the tibialis anterior become active, and especially when patient is walking. So during swing phase, this foot is goes into supination, and that is called the dynamic supination deformity of the foot. That is one of the cause of the recurrent of the clubfoot. The third problem is that there is an overcorrection, sometimes due to media release or over media release that lead to the heel in the valgus. And while the forefoot it become in the adductors, and that is called the skew foot deformity. And sometimes there is an undercorrection. Still there is a not, it means still there is a no reduction of the talonavicular joint. So these are the problem we face in this recurrent clubfoot after surgery. So how to treat this patient? One is the Ponsati treatment. Obviously, this is a treatment nowadays. And if this treatment is not possible, then we have other salvage procedures. So my discussion topic is mainly on the Ponsati treatment. So before the treatment, we have to assess the foot properly. So in steps of assessment, first is the assessment of all previous record about the surgical procedures done in the past. Then there is scoring. Actually, there is no universally accepted scoring system, but still few authorities use this. Few authorities use this. Few authorities are using this Pirwani scoring system to see the progress of the treatment. And then after that, we have to see the position of heel. Either it is valgus or it is varus. And then we have to see the palpation of the talar head on the lateral side. And then we have to assess the component of the cavus and adductors. And we have to see the suppleness of tarsal joint. Although these tarsal joints are very stiff in these cases. And then we have to see this the dynamic supination of the foot during walking. Actually, in the swing phase, the foot is go into the supination. And in this way, we will check the tibialis anterior power as well. Although clinically it is not possible, if foot is going into the supination during walking, it means the tibialis anterior muscle is overactive. At last but not least, that we have to get both the X-ray of the foot in the weight bearing view to see any bony fusion around the subtalar or ankle joints. So after this assessment, we will proceed to the treatment. For the Ponsati treatment, there are few indication of few contraindication for the Ponsati treatment. Is this a dynamic supination deformity of the foot? Then treatment is very easy, only just to transfer the muscle. And if there's a talar head palpable on the lateral side, then we'll proceed to the Ponsati treatment. Contraindication to Ponsati treatment is that heel invalgus. If there's a skew foot deformity, this foot are not we cannot treat with the Ponsati treatment. Or if there's any bony fusion in the axis around the subtalar and ankle joints. So, how to treat with the Ponsati treatment? First step is the parent counseling, because these are the stiff foot and maybe need more casting, and ultimate result will be not as 100% as in the virgin foot. So we have to counsel the parents before starting the treatment. As foot is stiffer than the virgin foot, so may need more number of casting, usually up to 10 casts may need. The step of correction is same. First with the cast, we correct the cavus and abduction. And then at the end, we go for the correction of the equinus. In these cases, usually abduction could not achieve beyond the 40 degrees because these are stiff foot. In ideally, we should get up to 70 degrees. But if we see, we can achieve up to 30 to 40 degrees and the tailor head is covered laterally. So then mean it is now we have achieved the abduction. And after that achieving abduction, we will go for the correction of the equinus by T8 tenotomy. In these cases, usual aim is 10-degree dorsiflexion. Ideally, we need up to 30 degrees, but in this case, up to 10 degrees is also acceptable. Don't try to get further correction of the equinus by doing posterior tenotomy or posterior release of the capsule or any further procedure after after tendon, because any further release in the capsule will lead to further stiffness, and with the growth, this equinus become more severe. So after this correction, in the follow-up, we should start with the bracing. This also depend on the age of the patient, because bracing should be continued after the age of 4 years, because relapse is uncommon after 4 years. However, if the child is having still relative tight Achilles tendon, 10 degrees of dorsiflexion continuation brace for another year may be helpful, as well as performing stretching exercises of Achilles tendon. At last but not least, we have to transfer the tibialis anterior muscle. But usually the recommended age is more than 30 months. Why in 30 months? Because the uniform bones are ossified at the age of 30 months. If it is not ossified and we transfer the muscle, we will not get the benefits of transfer as we get after the age of this 30 months. This transfer is also help to prevent the recurrence of deformity. It is not only recommended in the supination deformity, it is routinely transferred if the child is aged more than 30 months to 36 months. So then this is the algorithm, and this is a summary of whole my discussion. That if a patient comes with a foot deformity after surgically corrected foot and there is a recurrence, so what we will assess, we will see either there is an overcorrected valgal foot or not. If yes, then it is not eligible for the chemotherapy treatment. We have to use some other method. If no, then we go to see any bony fusion. If there is a bony fusion, again not eligible for the Ponsati treatment. If no, then we accept it for the Ponsati treatment and we go the patient counseling and we will start sear manipulation. So the aim is for the manipulation is the reduction is up to 40 degrees. If we can achieve it up to 40 degrees, or some authorities said up to 30 degrees, then it's okay. We go for the T8 tenotomy. If we could not achieve this reduction, and this is 10 casts is already done, 10 casts is already done, and we could not achieve our target, then maybe this patient needs some other surgical procedure with Ponsati treatment, we could not get the correction. If we can achieve up to 30 degrees of abduction, then we go for the performed T8 tenotomy. And we should apply a cast and remove it up to 4 to 6 weeks. At this point, I can add if the child age is more than 3 years, we can add also tibialis anterior tarsal in this treatment as well. And if we achieve more than 10-degree dorsiflexion, and when few authorities say even up to the neutral, so then we should apply a brace. If we could not achieve even neutral dorsiflexion, then again we do consider some other surgical procedure. If we can achieve this, then we will apply the brace, and this should continue, and we will follow patient every 3 to 5 months. If remain fully corrected and child age is more than 4 years, then we should discontinue the brace, and we will follow till the maturity. If no fully correction, then we consider for the surgical procedure, other surgical muscle. Even if discontinue at any stage, we could find there is some recurrence, we should consider for the further surgical procedures. So final acceptable outcome after Ponsati treatment, first should be demonstrate maintenance of the correction, at least up to neutral dorsiflexion. In some patients, slight amount of residual adduction and cavus could be compatible with the good function. This is our final aim. So suppose this patient is not could not treat with the Ponsati treatment, there are other various options, and because this is a lot of detail required, I just summarize it. First is the correction is with the Elizor. This is also very excellent excellent method in the expert hands. But in my experience is that even correction with the Elizor, you will get a good looking foot, but again stiffness is there. It is good looking foot, but not a moving foot. The other bony procedure is that, there's a shortening of the medial side and lengthening on the lateral side. So we can do some procedure for the medial column lengthening osteotomies. This depends on the cora. And you can go for the lateral column shortening osteotomies. You can go for the calcaneal osteotomies for the correction of varus or valgus. Or sometimes you can go for the tracheotomy, especially in the syndromic foot and very stiff foot, and even you can end up with the triple arthrodesis. So thank you. This is the end of my talk. Any question you are welcome.
Okay, thank you, Dr. Peracha, and very rightly said, with any kind of surgical correction for a congenital talipes equinovarus, you cannot get away with the stiffness. So we move on to the next talk by Dr. Nusrat Rasheed.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Nusrat Rasheed, working as Associate Professor in Dow International Medical College, Orthopedics Surgery Department. So the topic of my today's presentation is management of clubfoot in working age group patients, or the adult clubfoot. So literature pertaining to adolescent or the young patients with a history of congenital clubfoot is very scarce. Actually, low and middle income countries, there are adult patients with neglected congenital talipes equinovarus that remains untreated because the patients have limited access to surgical centers, or there are no skilled surgeons available to treat these deformities. Ultimately, the late sequel of the treated congenital clubfoot deformities occur, and these complications are recurrent or residual deformity like the cavus, heel varus, and the forefoot adduction, pain and limited ankle and subtalar range of motion, abnormal gait, small foot and with the dorsal bunion, weakness of the foot, altered plantar pressure, degenerative joint changes, and limitation of shoe wear. Actually, management of clubfoot is the most difficult group in the whole scenario of congenital talipes equinovarus. Each patient must be evaluated carefully to determine which treatment would best correct the particular functional impairment, because the patient, when the patient come to us, already the foot is so stiff, and keeping in view the financial and the social condition of the patient, it is very difficult to tailor a particular management plan for that patient. So we have to evaluate thoroughly, and we have to see each and every deformity individually, and then we should make a plan how to treat that particular patient. So for that, we need to examine the patient, and for that examination, assessment and forefoot and hindfoot is mandatory. We have to see the range of inversion and eversion of calcaneus, and we have to assess the plantar and dorsiflexion of the ankle. So if we talk about the treatment for adult clubfoot, it is, as I have said earlier, it is very difficult because in the younger age group or the non-walking age group, we have a Ponsati method, which has become used worldwide, and the result, and we are doing it successfully all over the world. On the other hand, in adult age group, we have very limited treatment options. So if we discuss in adult age group, Ponsati method is likely effective to treat the neglected clubfoot in children after the walking age. But there are some modifications which we have to do, and these modifications are essential. For example, the bracing protocol, which is different in children, but in adults, we have to modify it because in a walking age group, it is very difficult to apply the DB shoes.
Open lengthening of the Achilles tendon, which is often becomes mandatory. Rather to tenotomy, we have to go for Achilles tendon lengthening. So these are some differences which are among the walking and non-walking age groups. On the other hand, if we discuss about the Ponsati method, which has potential for satisfactory correction of recurrent clubfoot after posterior medial, even after posterior medial neurogenic or arthrogrypotic clubfoot and relapse. So first of all, when a patient comes to us, we have to categorize the patient. First of all, we have to diagnose either the patient which we are dealing with is clubfoot infect or not. Because most of the time what happens when a patient comes to a clinic, the resident label them as a case of clubfoot, and when we examine the patient, we come to know that it is a case of simple metatarsus adductus. So number one, we have to diagnose, or we have to categorize either it is a clubfoot, and then we have to categorize it, either it is an idiopathic one, neurogenic, or a syndromic. And then we have to individualize the patient according to the management plan. So correction can usually be obtained with an average of 7 to 9 casts, but variation can occur because in children, yes, number of casts can range between 7 to 9, but in adults, there is no fixed protocol that this number will, treat the case. But in adults, we have to apply cast, and even we can extend the gap between the two casts up to 2 weeks, especially in children older than 4 years of age. So we had a case of neglected clubfoot 15-year-old, and this patient managed conservatively, resulting in plantigrade foot. So this neglected clubfoot was managed conservatively with Ponsati technique. So this patient was not from our clinic. We have taken this scenario from some other clinic. Anyways, obtaining 10 degrees of dorsiflexion. Obtaining 10 degrees of dorsiflexion is rarely accomplished entirely by casting. And so most commonly, after attaining 10 degrees of dorsiflexion, we require tenotomy of Achilles tendon. Before performing the tenotomy, the foot should be adequately abducted so that the head is fully covered laterally and varus of the calcaneum is corrected. So these are the same prerequisites which we have in the walking age group. Similarly, after the tenotomy, we apply cast for 3 weeks. But in very rare stiff cases, dorsiflexion may not be 10 degrees. And in that scenario, we can go for post-tenotomy casting that can be performed to obtain the desired dorsiflexion, and it can extend up to twice. So these are some variations which we have to do while managing the adult clubfoot management by Ponsati technique. Attempts at further casting or another tenotomy may lead to the development of a complex clubfoot. So we have to be very vigilant while managing these cases. In those cases, we have to extend our casting more than 10 or 12. In these scenarios, we should take a consultation from any clubfoot champion or any senior consultant, because if you are facing a problems, you are doing casting and the casting has extended up to 12 or 15 and you are not getting the desired result, in those cases you should consult some opinion from a champion by Ponsati champion. So if the complication occur during further casting and tenotomy, that may lead to development of a complex clubfoot, and we are very aware of that. It is very difficult to manage the complex clubfoot. So in subsequent follow-up visits, the foot should demonstrate maintenance of correction with no cavus, varus, and approximate 10 degrees of dorsiflexion. जब हम casting हो गई, tenotomy हो गया, उसके बाद we have to follow the patient, that patient को जो हमारा desired target था वो achieve किया है या नहीं, उसमें cavus और varus correct हुआ है या नहीं, 10 degree of dorsiflexion हुआ है या नहीं. If any of the component of the deformity are present, a relapse may be present and that may require further treatment. So we have to assess the patient again and again during the course of treatment. So in any stage, if you are stuck with any problem, you have to revise your management plan. In some of these patients, a slight amount of residual adductors and cavus can be acceptable provided it is compatible with a good function. So we have to see the compatibility with function. What happens actually sometimes, there are some residual defects or the residual deformities like a slight adduction in cavus. But if it is not creating a problem with the function and it is compatible with function, we can accept it, and we have to counsel the patient that we can manage it as it is, and we have to accept this residual deformity. Okay, except in very unusual cases, mostly applying more than 10 casts may indicate very severe stiffness, other conditions, or inappropriate manipulation in casting. So as I have said earlier, if number of casts are increasing day by day, every week you have to apply a cast and you're not getting the result, then you have to sort it out. What is actually the reason? Either the manipulation is inappropriate or the casting is inappropriate. So in this scenario, you should consult some senior orthopedic or some senior consultant. Failure to achieve correction of the deformity following repeated casting and tenotomy may indicate, as I have said earlier, inappropriate manipulation. So anytime you can end up or you can do any type of surgery, so you have to think about that and you have to discuss about that. It is not necessary that every patient with which you are starting with Ponsati, it will correct 100%. So anytime you can have surgical intervention, anytime of the treatment. So you have to make a management plan according to that scenario. So we have certain algorithms which have been made by the clubfoot champions in Barcelona. So these algorithms have been made for a particular scenario. So it is different for idiopathic clubfoot in non-walking age group. It is different in walking age group. You have to do the parents counseling. You have to do the serial manipulation in casting. If you have achieved 60% of abduction in dorsiflexion, you will go for tenotomy. Apply cast and remove that cast after 2 to 3 weeks. If you have achieved 20 degrees of dorsiflexion, yes. If you have achieved 20 degrees of dorsiflexion, you have to apply brace, and you have to counsel the parents attendant, and you have to follow every 3 to 6 months till it is fully corrected. If it is fully corrected, then you have to discontinue the brace and monitor till maturity. In any stage of the scenario, if relapse occur, then you have to treat according to the relapse guidelines or the relapse algorithm. So we have an algorithm according to management of idiopathic clubfoot. These guidelines were made by Ponsati champions. So in this algorithm, patient with foot deformity in working age, when the patient come to us in OPD, we have to do the parent counseling. And after the parent counseling, we do the serial manipulation and casting. So after casting, we have two scenarios. One is either we achieve 30 to 50 degree of abduction and 0 degree dorsiflexion. If yes, we achieve our target of abduction and dorsiflexion, we go for tenotomy. After tenotomy, we apply cast and we remove it after 2 to 3 weeks. If we are not able to achieve 30 to 50 degree of abduction up to 10th cast, then we should seek additional consultation. On the other hand, if after tenotomy and applying cast and then removal of cast, still you are not able to achieve 10 degree of dorsiflexion, you have to go again for remanipulation and casting. And if you are able to achieve 10 degree of dorsiflexion, you have to apply brace and you have to do the parents' education and counseling on each and every visit. And then you have to follow the patient every 3 to 6 months. So now it has become very clear that after tenotomy, if you have achieved 10 degree of dorsiflexion, go for bracing, do the parents' counseling and follow every 3 to 6 months. But if you have not achieved 10 degree dorsiflexion even after tenotomy, then go again for remanipulation casting. And after third cast, even after third cast, you have not attained your target, seek additional consultation by any Ponsati champion. So on the other hand, if you have applied brace and you are following the patient and you have kept the patient in follow-up every 3 to 6 months and it is fully corrected, then you have to keep the patient in follow-up for 1 year post-correction, right? But during the tenure of your surveillance or your observation, if you see any sign of relapse, then you have to follow the guidelines of relapse and recurrences, right? So if everything is going okay, your patient is okay, then you have to discontinue brace after 1 year of correction, right? Then you have to monitor the patient till maturity. And if the correction is maintained, it is okay. If the correction is not maintained, again, you have to treat the patient on relapse and recurrence guidelines. And at any stage, if you are facing problem, you can seek additional consultation by any senior. So if you review the literature, the treatment of congenital clubfoot with Ponsati method for neglected case was first reported in 2008, when good results were described in patients up to the age of 8 years. Khan and Kumar reported positive outcomes with the Ponsati method in children suffering from neglected CTEV, with one of the patients being 11.1 years. Haje previously reported successful treatment of a 12.9-year-old pre-adolescent patient, and later Adi Benge et al. Treated cases at a maximum age of 16 years. It is not established the bracing protocol in older children, and if the results in relapse may change according to specific age group during or adolescence. So, as I have said earlier, the last case was 16.1-year-old adult who was treated with Ponsati technique. Then we had a case report which was published in Journal of Orthopedic Cases, July 2020. This neglected idiopathic clubfoot was successfully treated by Ponsati method, and that unique therapeutic success in adult female patient which was previously neglected was treated at the Ponsati clinic at the age of 26 years. So this is the maximum age limit till reported, So these are some pre-treatment pictures, and she was managed with conservative treatment, and then you can see the results post-treatment. Okay, so we had a study of Ponsati method after walking age, a multicentric study of 429 feet. Results, possible treatment modification, outcomes according to the age group. This article was published in Iowa Orthopedic Journal 2020 in 40th edition. And the conclusion of this article is Ponsati method is effective to correct neglected club feet. Relapse occur in 1/3 of club feet, mainly in children younger than 4 years and in non-compliance with brace. Our study reinforces the recommendation for the Ponsati method with no major modification to treat neglected clubfoot in patients after walking age. So, as I have said earlier, surgical option is there. So, surgery in the clubfoot is indicated for deformities that do not respond to conservative management by serial manipulation and casting. Often in children with a significant rigid clubfoot deformity, the forefoot has been corrected by conservative treatment, but the hindfoot remains fixed in varus and equinus, or the deformity has recurred. Surgery in the treatment of clubfoot must be tailored to the age of child and to the deformity to be corrected. In general, the older the child, the more likely it is that combined procedure will be required. Children 2 to 3 years old may be the candidate of modified Mehtab procedure. But if previous soft tissue release has caused stiffness of the subtalar joint, osteonecrosis of the talus, or severe skin contracture, then osteotomies are better choice. Children older than 5 years require osteotomy for correction of resistant deformity. 1 to 5 years old constitute a gray area in which treatment guidelines are unclear and careful judgment is required. The separate component of the residual deformity must be assessed accurately and the treatment directed appropriately. Common components of the resistant clubfoot deformity are adduction or supination, or both of the forefoot, a short medial column or a long lateral column of the foot, internal rotation, and varus of calcaneum and equinus. Evaluation of the hindfoot should determine whether the deformity is caused by isolated heel varus or a long lateral column of the foot or a short medial column. In children younger than 2 to 3 years who have no previous surgery, residual heel varus may be corrected by extensive subtalar release. But children 3 to 10 years old who have residual soft tissue and bony deformities usually require combined procedure. Correction of forefoot with residual adduction or supination or both is similar to correction of isolated metatarsus adductus by multiple metatarsal osteotomies or by combined medial cuneiform and lateral cuboid osteotomies when the deformity is in the forefoot. Because dynamic supination and adduction often caused by the overactivity of anterior tibial tendon and underactivity of the peroneus tendon, Q et al. Suggested that a tendon balancing procedure is the most reasonable solution. Isa et al. Reported good results after transfer of anterior tibial tendon in 27 previously treated clubfoot with residual dynamic supination deformities. So here is an article regarding arthrodesis of the foot and ankle in congenital talipes equinovirus. So the conclusion is flexible deformities may be treated with a combination of soft tissue procedure and osteotomies or limited fusions, which will not compromise the essential joints of the ankle, subtalar, and talonavicular joints. More rigid deformities require fusions with their associated functional loss in an attempt to obtain a plantigrade foot. So these are some complications after surgery. That is, it can occur residual cavus. Residual cavus results of insufficient plantar release and or placement of navicular in dorsally sublux position. Pes planus results from overcorrection. Intoeing gait commonly due to internal tibial torsion or internal rotation of talus within the ankle mortise. Osteonecrosis of talus can occur dorsal bunion and osteoarthritis. So conclusion, in low and middle income countries, there are adult patients with neglected congenital talipes equinovirus that remains untreated because the patients have limited access to surgical centers. So in these patients, Ponsati method could be an option for the treatment for adult neglected talipes equinovirus cases. Thank you.
Nusrat. So it has been a very good session since morning, and we have talked about how the Ponsati treatment is done, how it is better than the surgical, conventional surgical management. And now I would give the last talk in place of Professor Kamran, and I would talk about a different facet of the same problem, and which is the economic burden of the clubfoot treatment. So if you can all see the slide, I'm Dr. Syed Ali Anwar Jillani, and I'm working in the Hindus Hospital as a consultant orthopedic and sarcoma surgeon. So we want to see how the Ponsati treatment is better in terms of cost than the surgical counterpart. And we want to estimate the lifetime economic value of returning a child to a full and productive life. We want to estimate the cost per patient treated using Ponsati versus a surgical method in Pakistan, and to estimate the cost effectiveness of clubfoot treatment using the Ponsati method. So we did a small survey, and we are dividing the cost into two parts. The cost that is borne by the patient and the family, which is not utilized in the hospital, pre-hospital cost. And then the second part is the hospital cost, what it cost us to treat the patient in the hospital. So for the patient cost, we did a household survey for utilization, treatment, productivity, and in both the Ponsati and the surgery group. And we looked at the direct and the indirect costs, and we collected that data. And we divided into three parts. The pre-diagnosis period, the cost in the pre-diagnosis period, the cost of inadequate treatment before they reached Indus Hospital, and then the current treatment at the Indus Hospital, how much this will cost. The indirect cost that we are referring to is the loss of income to the family while the time they are present in the hospital and doing the, and also for a lot of little costs that is not calculated per patient, but actually goes into the whole working of the system, like the housekeeping and the security staff. They are not directly involved in the treatment, but they do have a cost that the hospital bears. And then the hospital, and then the cost that the hospital bears is amount accounting to the salary for the whole staff, the outpatient clinic visits, the lab, pharmacy, hospitalization, surgical cost, and if we are doing the Ponsati, then the program cost, because we're not treating one patient independently, we are doing it in a programmatic approach. So we enlisted 56 patients in the Ponsati group and 48 patients in the surgical group. And the important thing here is the mean age for the treatment of Ponsati group was around 4 months, and for that in the surgical group around 4 years. So essentially, this one point that came to us was that when we're doing Ponsati treatment, we are actually treating the patients earlier than in the surgical group. And the other important thing here that we accounted was that because we are in a low income setting, the mean average income of a family who are coming for treatment is around $122. So we come to the patient cost. So in this chart, if you can see, the total cost incurred by the patient till they reached a diagnosis was $39 in the Ponsati group and $94 in the surgical group, because of the number of visits, the transport charges, and also because they had to undergo various multiple other investigations that are essentially not required in the Ponsati method of treatment. So cost incurred by the cost already paid by the family before coming to Indus Hospital, that they had already spent for their treatment, was $92 in the Ponsati group and $176 in the surgical group. we were also enrolling the patients who have had Ponsati cast before they came to our hospital. So the third part was the cost incurred by the patient during the current treatment, which they got at the Indus hospital. This is the cost that is paid by the patient family and not involving the actual treatment. So it amounts to $48 in the Ponsati group and $94 in the surgical group, and it accounts for all the food and the time they are spending, the visits they are doing. So actually, it's amounting to the cost they are spending while coming to the clinics by the family themselves. So total cost in all the three departments were $179 in the Ponsati group and $364 in the surgical group. This is a chart showing the same, and you can see it's almost a double when you look at the surgical aspect with the surgical cost, and when you compare it with the Ponsati, it's almost the double. So what did we spend in the hospital? Because we are a private free patient, free of cost to the patient. So there's a amount of money that the Indus hospital itself spends on the patient, and it's not spent by the family. So how much did we spend on each patient? So in the Ponsati method, the cost incurred by Indus hospital per patient was US dollar 124. This is the cost for one patient. But when we're running a clubfoot clinic and we are doing in a programmatic approach, and we are collecting the data and shifting it to the Ponsati side. So there is a small cost for the program also, and that cost amounts when we calculate amounts to around $170 for the salary of the personnel and for other communications and operational costs. So what is the cost incurred by Indus hospital per patient when we're doing this surgery? So it amounts to around $452, including all the bed charges, labs, pharmacies, surgeon anesthesia fees, and operating and consumables. So the total cost incurred by the patients at the Indus hospital, when we calculate all of it, it accounts to $349 in the Ponsati group. That includes the cost spent by the family and that spent by the Indus hospital. So it is $349. While in the surgical group, the patient spent $452 spent by the hospital and $364 spent by the patient family. So as you can see, it's more than double. The total cost for the Ponsati group is $349, while it is that $816 in the surgical group. So to conclude, the Ponsati method is cost effective when we compare it to surgery. The families incur significant cost before and during the diagnosis. This cost is that utilized while bringing the child to the clinic, while waiting here, losing the important salary, that because most of our patients are families are having a daily wages system. So every hour they spend in the hospital, they are losing something at the other end. So the families incur significant cost for this treatment. And when we're doing the surgery, more people of the family are involved, because when the child is undergoing surgery, a multiple number of people from the family would not go to work and come and sit in the hospital, because this is what our system around is in our country. So the other thing is significant amount of money spent in seeking the treatment, because they are going door to door and shopping for how who to get the treatment from. So which and the treatment at the end is often incomplete and inadequate. So in to end my talk, I would say uh, in a programmatic approach with the Ponsati method, it is just not that the outcome are better in terms of function and in terms of the outcome of the patient, but also in terms of the cost that the patient and the hospital spend on treating that patient. So that concludes my talk. So we can, and in the interest of time, because we have been now, I can say we are in time to conclude our session. It has been a very wonderful session. And can you take all the Professor Amin, Chinoy, and Professor Mansoor, all the speakers on the panel? Okay. So it has been a wonderful session, especially in the first session, we had very good attendance, and we were nearing 50 participants altogether. In the second session, the attendance was a bit low, but we have had a good participation overall in both the sessions. So, Dr. Mansoor, you would like to say a few words before we come to an end? We have to
Yes,
close
I
by.
will compliment all the speakers in this second session. This was a very difficult session because talking about guidelines, protocols is actually very, very difficult. And to keep it interesting, Mehtab and Asif, Nusrat, and obviously Dr. Amin, who wrote the guidelines, they know how to do it very well. So I think it was very difficult to keep it interesting. It may look a bit dry, but it is very important to realize that if you don't know the guidelines, how can you treat? It's just like not knowing the roadmap to go to a particular destination. If you don't know the roadmap to the destination, how can you reach that destination? So well done, everyone.
Is
Professor.
Dr. Mehtab and Nusrat and Asif Peracha online?
They were in, but at the moment we have lost them due to net issues, probably on their side. So we don't have them right now. You can go ahead and conclude the session.
Are the residents over there? Any questions from them at all?
If I can have any questions from the residents, I can see around maybe 17 people at the moment. But I don't think they have a question at the moment.
Right, then I think we should thank everybody and we should close this session then.
So thank you, sir, for some concluding remarks, Professor Minchana.
Okay, thank you very much. I think it was a very, very useful and fruitful session, barring some technological hitches in Pirwani's talk. Otherwise, I think it was talks were brilliant, especially Jose and then Monica, Shafiq Pirwani, even Mansoor and Anis Bhatti, which actually gave a overview of the whole Ponsati treatment and the programs. And then the second part was the algorithms and the guidelines and that were developed and that we have implemented at our place and all the other centers doing the Ponsati treatment. So overall, I think for the residents and participants who have not had the exposure to these guidelines or understand the basic behind the development of the guideline, I think this was very important. I hope that our presenters have been able to make them interesting enough for the participants to stay connected and awake and understand what is being presented. with that, I would conclude and thank everybody who has participated and attended this session. Thank you very much.
And in the end, we thank Allah for giving us this opportunity and to present the people that we have from outside Pakistan. And I would like to thank all the panelists, Professor Jose Marquende, Professor Shafiq Pirwani, and Professor Monica Nogueira, Professor Anis Bhatti, Professor Mehtab Pirwani, Asif Peracha, Dr. Asif Peracha, and Dr. Nusrat Rasheed, and my very own Professor Muhammad Amin Chinoy and Mansoor Ali Khan. I thank all the participants for participating in this broadcast, and ciao.